Right. Good evening. Thank you all for attending this inaugural lecture, colleagues, friends, and those people who are here because they are interested in allergies. So I'm going to share with you, let me just time, because there's a timer here, and I just want to make sure what time, 20 to 7, so time me from now. I'm going to share with you my journey as a researcher, how I came to do this research, and my kind of the studies I carried out, how my achievement to date, and hopefully give you an essence of what is to come in future as well. So, I was born in Iran in 1962. I asked my mom to share some photos with me. And when she sent this to me, I said, oh my goodness, that's when I stopped looking cute. I was quite surprised at those pictures. That's when what happened to me. But in Iran, as I grew up, I was one of 4 children, eldest of 4 children. And I did relatively well at school. My passion was literature and art. I was particularly drawn to Russian literature, 2 particular authors, Maxim Gorky and Mikhail Sholokhov. And if you haven't read Quiet Flows the Dawn by Sholokhov, I really seriously recommend it to you as an epic novel. I really wanted to study art, but that wasn't a career that I was encouraged to pursue, a route that I was encouraged to pursue. Around the age of 15, 16, I started to become very interested and very involved in what was the political movement at the time, which led to Iranian Revolution. So on a weekend, my weekend activity when I was around 15, 16, meant I usually attended a demonstration on the build-up to the revolution. And at the time, the slogans which were branded in, there was no notion of religious background to the revolution at the time that it took place. It was all around democracy, freedom, and social justice. I got into trouble on 3 different occasions, and on each occasion, my dad had to come and persuade them to release me from wherever they had held me, and I then went back out again. The turning point in Iranian Revolution was something which is referred to as the Black Friday on 8th of September 1978, where the student body, both at high school and at university, were going to do the biggest march. And in fact, it was the biggest march. But the government at the time, in the morning of the day of the demonstration, declared a curfew. And that was unknown to many demonstrators, including myself, who went there with many friends. On this one demonstration alone, 15,000 people were killed, and it totally turned the course of the revolution. I got back home safely. I wasn't arrested on that occasion. And when I got back home, about a week later, when I returned from the school, an aeroplane ticket was on the dining room table, and my father announced that I was on a plane in 2 days' time coming to UK. I really didn't have much option. I accepted. I was quite upset to be leaving the country when things were very much looking like there was going to be a successful revolution and overthrow of the government. Things didn't quite work out for Iran as I had planned that it would. But I came to UK, and the UK that greeted me was this. Quite different in the late 70s. The punk movement was very strong. The skinheads in the little town that I was sent to was rife. They were everywhere. I was actually quite frightened for different reasons, much more frightened than attending demonstrations in some ways. Nevertheless, I stuck down, did my O-level, remember those, A-levels? And I went to University of Essex to do biological chemistry. My father was very pleased that eventually I saw sense and I pursued studying science. And while I was at the university, I worked part-time initially with the Student Union. I was what the Essex Uni called Liberation Officer, a lovely title. All that meant is I was in charge of ensuring that the student body attends different demonstrations in London. And I did that pretty well, and I attended them myself as well. And after my degree, I was a sabbatical officer full-time working at the union for 1 year. And in that time, Essex was quite a kind of unique place in many ways. The student union had a logo, and the logo was "No platform for Tories." And in that year that I was the student union president, I had a lot of dialogue with a young chap that you may not recognize here, but I'm sure you would recognize him from this photo, who was very keen to set up a conservative club on campus. He didn't have his way, but his career hasn't seemed to suffer that much. So after my degree, I went to King's College London in Department of Pharmacy. At that time, it was on Manresa Road, to do my PhD. My PhD supervisor, Bob Hyder, I really learned all there is about PhD supervision from him. He had a large group, a very successful group and a very large group, but he really supervised us all passionately, and we could, contact him almost any time of the day. I did my PhD in drug delivery. The title of my PhD is there. Once I finished doing the laboratory work, I still needed to write up. So Bob's advice to me was, get a postdoc job just around the corner somewhere here, and then you can come and see me lunchtime and in the evenings. I wasn't really particularly fussed what field this was at. So with that in mind, I applied for a position in National Heart and Lung Institute, and that was my first postdoc, to work with Sir Mahdi Yaqub, who brought heart transplantation to this country, and the first person who did heart and lung transplantation. A phenomenal chap, and my first project involved a disease in cystic fibrosis. And by working with him, I realized you need very few hours of sleep, because he did his best surgeries at 3 a.m. onwards. His wonderful team had to all do the surgery starting at 3 a.m. So when I was working with him, I started to be accustomed to really rather early starts, because I had to be there to kind of harvest the lobes that he was removing from CF patients to do my experiments with. Once I was there, quite accidentally, I was asked to comment and be involved on a different project by somebody else on milk allergy, which I did, and I was successful. I was quite surprised by that, and I started to think, what is this allergy thing about? And read about it, got involved in this project, and I was very lucky to have been sent by the team for a period of time to do a second postdoc, a short time, at Johns Hopkins Asthma and Allergy Center in Baltimore, UK. That was really happy times. I learned a lot through working intensively with a group of young, mid-career and very established researchers in an area that I was quite hungry to learn about. In the UK in the 90s, I joined University of Southampton. I worked primarily with Stephen Holgate. A lot of my asthma work was done with Stephen Holgate, and a lot of my food allergy work was done with John Warner. But it was a strange time, because I was a senior research fellow, a lecturer, senior lecturer, but all the time I was on fixed contract. On contracts that meant that I had to apply for research funding to ensure I have my own salary and the team that I was working with. And I had a reasonable team. I had PhD students, I had medical doctors doing their MDs with me, research assistants, postdocs, and so on. And of course, at Southampton, there is a unique way of introducing, but it's not unique anymore, it was at the time I was there, where all the fourth-year medical students are taken out of their studies, and for 1 year alone, they just do research. So there was an endless supply of medical students working with research teams around the campus. But I was getting a bit sick of these multiple grants and slicing my salary in number of grants. A position came up for me to apply for a job at the University of Oxford to work with an eminent researcher there, not in the area of allergy, in the area of evidence-based healthcare, the late David Sackett, and I grabbed it. And I worked with him for a number of years there. Towards the end of this time, David Hyde, the late David Hyde, whose picture is there, a lovely pediatrician who was at Southampton, said, what about coming with me to the Isle of Wight to set up a tailor-made, purpose-built asthma and allergy research center and help me run it? And then you don't have to worry. You still have your contact with University of Southampton, and you don't have to worry about securing your own salary as well as your team. I grasped that opportunity. Sadly, 2 months after I started, David died. And it left me with a center really to kind of build from scratch. But the center is very well known and very well recognized internationally. After this period, I joined University of Portsmouth, as Chris said, and I moved through the careers and eventually left Portsmouth to join you here as a dean. That's really how I came to my field of studies. I'm going to now take you to the actual area, allergies. The term itself is actually a conjunction of two Greek terms. It was coined by an Austrian pediatrician back in 1906. When you think of allergies, it's just not one disease, it's a number of conditions. And I've highlighted in red the conditions that I have worked very closely with. Today, I will only be talking about food allergy and eczema, but I have done also work with hay fever and asthma. Often when you refer to these conditions, you refer to these conditions being present in atopic individuals. Atopic individuals, and atopy generally, is a genetic predisposition. I have a slide which is not particularly well focused, but bear with me, I will explain the phenomena to you. So, if you are born and you're both biological parents, none of them have any of the allergic conditions, and that's around 70% of the population, you are likely to have one of those conditions. 15% are likely to have one of those conditions. If either the mother or the father has one of those conditions, then your risk of developing allergy as their child increases to around 30 to 40%. And around a quarter of the population are born to those sorts of family history. Then if both parents have a history of allergy, your chance of developing allergy is significantly increased, as much as 50 to 80%. And that's only a small population across the globe who have that. So when we talk about allergy, we often refer to high-risk families. And high-risk families are families where either the mother or father, or indeed both, have got the history of one of these conditions. Globally, it's estimated, the World Allergy Organization has estimated that around 10 to 40% of the population have one or more of the conditions I listed earlier. It is estimated that by 2025, half of the European population will have one of these allergic disorders. So it's quite a scale. I'm going to now focus on food allergy. So let's talk about food allergy. Let's talk about the terminology first. The umbrella term is actually food hypersensitivity. You wouldn't believe how many years it took many researchers, clinicians, and scientists to come to agreement on this one single slide. Okay. So, food allergy is the phenomenon where your immune system is involved, and it's non-allergic food hypersensitivity, or commonly known as food intolerance, is where the immune system is not involved. I understand we have Professor Hobson in the audience. Yes. Very happy birthday to you, Andy. It's very good of you to come this evening on your birthday. Now, Andy, I'm sure you don't mind me sharing that Andy, in fact, has got a food intolerance, not a food allergy, because he is lactose intolerant. So his body is not able to break down the milk enzyme lactase. That's quite different to food allergy. That's also a cue for you, Andy, to leave now. That's all I have to say about food intolerance. Most of the work I have done is with the IgE-mediated food allergy. This is the sort of quite immediate, quite severe responses. When you come across many newspaper clippings, you will see tragic deaths due to accidental ingestion of a food allergy by somebody who's been allergic to peanut, milk, whatever. These are all type 1 IgE-mediated food allergies. Now, let me talk to you a little bit about symptoms of allergies. Now, I think for me, really the biggest manifestation of food allergy, having worked in the area now for a couple of decades, is the impact it has on the quality of life of not only the person who has the allergy, but also on the entire family. One of my old PhD students, Dr. Heather Mackenzie there, in fact, that was the entire of her PhD, was to establish a measure for measuring quality of life in teenagers and children with food allergy. It's a lovely tool, it's validated, it's translated into 3 different languages, and it's used widely across the allergy clinics in the UK now. It does have an impact on the well-being of the whole family. But the symptoms, the physiological symptoms, affect a number of organs, and there are a number of symptoms. So they do affect your skin, they affect the respiratory tract, as well as the digestive tract. The most immediate symptoms which are often seen in food allergy are the skin reactions, characterized by itchy eyes, hives, rash, and swelling of the tongue and the mouth. So this is kind of a pictures, different slides of a typical IgE-mediated food allergy. The top middle picture, in fact, is my son, who is in the audience, who had an allergic reaction, and he was begging me and asking me to rush him to the hospital. I said, not until I take some nice pictures first. The bottom ones, the gentleman at the bottom is a professor at University of Portsmouth, and the first picture is how he normally looks, but he's actually got quite a severe allergic reaction to peaches, which he's quite partial to. So every time he used to eat a peach, and he used to rush into my office and say, take a picture of me, I'm swelling up as we speak. But those sorts of, these are typical type of reactions you can get. So how do you go about diagnosing this allergy? The cornerstone of diagnosis with any condition is a good clinical history and, of course, physical examination. But there are tests out there which can help. The most commonly utilized test is the test called skin prick test, and it measures the sensitization. So you put the allergen, whatever it may be, food, grass, dust, on the forearms normally, and you then prick the skin, and after about 15 minutes, you can immediately see a reaction. It's very rare that somebody has a type 1 immediate kind of type 1 food allergy who is not sensitized. So it's a good marker of type 1 allergy, immediate allergies. But of course, the proof of the pudding is in the eating. So food challenges are regarded as the gold standards. That is when you give somebody who thinks or suspects they are allergic to milk some milk. You may do this in an open way when you, as well as them, know they are consuming milk. You may do it in a single blind fashion where they may not be realizing that it is the real milk they are having as opposed to another liquid looking like milk. Or the gold standard, which is double-blind, placebo-controlled food challenges, where the food is prepared and the person who is administering the challenge and the patient do not know whether they are having the active or the placebo. I spent some time looking at diagnosis of food allergy. Believe it or not, for something which everybody refers to as the gold standards, there is very little research done on the dose you need to do these food challenges with, the vehicle you have to use, whether you bake the food, whether you have the food in a liquid format, on the timing between the doses, or indeed even the standard procedure. And I was lucky to have a PhD student, a pediatric dietitian, who wanted to study specifically this very phenomena. And we spent many times where we had a chef in our team preparing different type of food and then actually trialing the challenge material. Corina was her name. Corina is her name, Corina Venter. She in fact got an IHR fellowship to do that. And at the end of her PhD, the key finding from certainly first phase of her PhD was that most case histories, when patients tell you they've eaten something and this is the reaction they had and how it was, most case histories are inaccurate. And there is only a short list of food that affects 90% of the cases. And children, when it comes to children, they're often allergic to one or two foods only. So what is it in food that causes the allergic reaction? It is actually the protein content of the food. And in the 80s, where the papers I'm showing you, they're not in any chronological order, it's just to kind of weave a story for you. But it was very interesting to know what is it that different food, what is the allergic component of the different food. I had a postdoc who worked with me for a few years, Sally Kilbom, and it was her paper, we were the first group who demonstrate that actually food allergens are transferred through both placenta and mother's milk. So you can imagine the sort of experiments Sally had to do, and when she used to hang out to collect her specimens, and she was on call all the time. But that was quite an elegant series of studies, and we were the first group to demonstrate this. We also demonstrated that it's not just one protein, but there are a number of proteins in every food that could cause allergic reaction. This is a picture of Jonathan Houlihan. He's a pediatrician, but he decided to do a PhD in the lab. That was quite testing, certainly testing for him, but definitely more testing for me, trying to teach him to do various experiments. But to be fair, he was excellent. And he published some really elegant studies while doing his PhD and then stayed on to carry on his research. Then linking again, still with the food allergens, I had my first European project, well, I can't remember what exactly the date was, but that was exactly to look at different patterns of allergies in different parts of Europe. In UK, peanut is probably number one allergen, but that is not the case across the world, or certainly across this particular European project we did. Fish is number one allergen in Norway. Peach and celery in Germany. Olives in Greece. I think you start to think, these are the sort of food that they eat a lot of in those countries. So are they getting sensitized early on, or are they tolerized? Certainly, I spent quite a bit of time looking at the geographical variation of allergies across the country. Interestingly enough, in Israel and in India, peanut is in different format is one of the foods that is introduced very early on into the diet of babies. But peanut allergy is almost unheard of in these countries. So in UK, these are the big 8. And I already mentioned peanut being number one. And I worked with the exception of tree nuts, I worked with almost all the other key allergens. I'm going to just share with you a couple of studies I did, or a couple of areas in milk and peanut. Let's take milk first. Usually presents in infancy. Typical cases is an infant born, bottle fed, day 3, covered in rash, okay, from head to toe. That is a classic sign of a cow's milk allergy. The good news is When it comes to milk allergy, most children outgrow it. If it is IgE mediated, usually by 5 years of age, and earlier if it's non-IgE mediated. There are multiple proteins involved in milk, and most of them can cause an allergic reaction. They are usually big proteins, and up until certain time, the most commonly used formula for these infants were soy formulas. But the whole industry grew around the notion of hydrolyzed milk protein formulas. So here the idea was, these are big proteins. If you actually get these milk proteins and break them down to smaller proteins, then actually they're unlikely to cause an allergic reaction. And a whole myriad of products is now on the market, and I did quite a bit of work trying to assess the allergenicity of this so-called hydrolyzed formula. They are quite expensive. They are on prescription, ranging from 25 to 40 pounds for a 10. So they are very different to your regular infant formulas. Let's move to peanuts. This is drawing because what I didn't share with you, Jonathan Houlihan, who stayed and worked with me, used to love drawing cartoons of peanuts, and we had them all over the labs, and this is one of his drawings. You must have heard of somebody who has had peanut allergy, is that right? Yes, okay. There are many celebrities who who are suffering from peanut allergy. You may recognize all of them, or certainly recognize one or two. I know that a lot of the allergists in US were on call during Barack Obama because his eldest is quite severely allergic to peanuts. But the picture you may not recognize at the bottom is a picture of John Craven. He was the VC, the previous VC at University of Portsmouth, and severely peanut allergic. That was really good for me because he would never tire of hearing about my research. And believe you me, I milked it while I was there. So when it comes to peanut allergens, the contribution I had to the characterization of allergen was identify a protein called ARA-H2. Up until then, a group in Arkansas in US has identified ARA-H1 as the main peanut allergen, but our group actually established it was ARA-H2, and it's linked with more severe type of peanut allergy. I went about writing about peanut allergy, what is its characteristics, what is it, immunological responses to peanut allergy. The key thing about peanut allergy, actually, it's usually linked with severe reaction, usually lifelong, and it's unpredictable. So a small exposure, if you are allergic to peanut, on one occasion may lead to a very mild reaction. The same level of exposure next time may send you to A&E. So it's quite unpredictable. One of the earlier studies I did, this was a quite a nice study, but it was a survey. We went across the country. At that time, nobody knew much about peanut allergy in this country. And we went around and we asked mothers and children of those who were having proven allergies or suspected allergy or reported allergy to send in their samples through the post. That was quite an interesting ethical approval procedure, and also fill a questionnaire for us. And this was really the first study which started to have shed light on some characteristic of peanut allergy and whether mother's consumption of peanut during pregnancy could lead to sensitization in the child. The final message on this BMJ paper was very clear, that this is a survey-based study, and actually, if you ask a mother who's got a very severe allergic child how much peanut you consume during pregnancy, they are likely to recall every last bit of peanut they had much more thoroughly than a mother of a child who is not allergic. But somehow, the Department of Health got hold of this paper, and In 1998, the Committee on Toxicity of Food produced a report which suggested that if you are an atopic mother or you have a sibling who is atopic and you are pregnant, you should avoid eating peanuts. And this was actually interpreted very differently. This was the subject of the CMO at the time, writing to every GP in this country. And the NHS, in their advice, as you can see on that corner, they just added peanut to the other foods that you need to avoid. So the notion of this is actually for high-risk family was totally gone. I felt very bad as a researcher because I was thinking, would this actually lead to adverse reaction, to more peanut allergy, if nobody is going to eat peanuts during pregnancy? I wrote to the CUT committee. I also did a couple of studies talking about, is the government advice the right advice? Is it being followed correctly? Who is avoiding peanuts? But to no effect. Their worry was that if there is a link, they need to prevent it now and then, unless evidence comes on board that things have changed. So for a period of time, I got very frustrated, thinking that it is my research which has led to this advice, and I'm not comfortable with this research. So a couple of years after this, where we had a name for ourselves in the group as the people to come to for peanut allergy, we were approached by an organization I never heard of, Seed Crushers and Oil Processors Association. And they are the guys who produce groundnut oil, highly refined groundnut oil. Now, you may think, okay, if you're peanut allergic, you just avoid this. Well, it's not that easy because it's the most commonly used oil to carry flavor in already prepared food. So the industry was very concerned that actually if there is a risk that there is peanut allergens in here, they basically can't sell this product as they used to. So they approached us and they asked us whether we could do a study. Now, Jonathan said, yes, we could do it. And I said to him at the time, this means we're bringing peanut allergic people in the hospital and feeding them with peanuts. I am not too sure if I'm comfortable about that. But anyway, and I told him nobody will give us ethical approval, but we did it under a very controlled fashion in Southampton Clinical Trials Unit. And the paper was published, and I'm glad we did this study because the study made a real difference to people who suffer from peanut allergy, because our finding was that actually they are safe to consume this product. And that meant there was a whole range of stuff they could eat that they couldn't before. Doing this study was tricky because we had to, despite the fact it doesn't have any peanut protein, when you open a bottle of groundnut peanut oil, doesn't matter how refined it is, it stinks of peanuts. So we had to mask it, and we tried different things, and we eventually discovered Brazilian peppermint. Boy, oh boy, if you had that bowl of rice pudding laced with peanut oil and a drop of that Brazilian peppermint oil added to it, you couldn't smell anything else. And it was so strong that the participant complained, and they used to have a nose peg while they were eating it. So food allergy research, in the time that I started to get involved with it, it come a long way. But there was still one question we didn't have a good handle on in this country. Exactly how common is it? How many people have this condition? And I thought I was a scientist. I'd done up until then, most of my work was really focused in the lab. And I thought to do this sort of a study, I need to go back to school. So I went, to the amusement of my team, decided to do a master in London School of Hygiene and Tropical Medicine in epidemiology, so I can be trained to do these sorts of a study. And actually there I met a fellow collaborator I'm going to introduce you to very shortly. So I did this and I shared my learning with my team, And I was always going on about we don't have any good idea in this country how common it is. We really had only one study done in High Wycombe by the late dermatologist Elizabeth Young, who actually had a study bypass the whole population that is mostly affected by food allergy, the children. So when they did the test, they excluded the children. And I kept going on that we don't have any good data. And just by magic, just as I finished my master's, Food Standards Agency put a call out to say they are interested in better prevalence and incidence data. That was my best grant I've written. I was ready for it. I really gave it my heart and soul, promised everything in this grant, and I was delighted that we were successful. So the FAIR study was born. This is really what I'm most known for in the literature, the study of food allergy and intolerance research. The project was done on the Isle of Wight. It involved a number of cohorts. Isle of Wight has a birth rate of just under 900, something like that, per year, quite stable. And we wanted to have a birth cohort, follow this birth cohort from birth, and then have a cohort of 6-year-olds, 11-year-olds, and 15-year-olds. And the picture you see there is Jackson family, who had all 4 children, part of the FAIR cohort. They had a 15, 11, 6, and a newborn, all taking part in the FAIR study. The study attracted a lot of international publicity because it was the first time there was a birth cohort and a whole population study trying to objectively assess food allergy. There was lots of study on asthma, but nothing on food allergy. So when we look at the birth cohort, we recruited the mothers in antenatal clinic. We took really good history detail of the mothers, their living conditions, where they were living, the social economic class, everything, what they were eating, and then collected the information at birth from on the children, and then followed the children at different time intervals. A study like this is very frustrating because you are in a unique position to do something that nobody else can, but in terms of short-termism funding of research, people don't necessarily want to fund you to do a piece of research where in 5 years' time you may find something which is quite helpful. They want the results, something which will have an impact very short term. But we carried on, and in fact we had a 10-year follow-up very recently. The birth cohort were very straightforward because everything was under the control of the parents. The school children, on the other hand, was quite tricky. The Isle of Wight had around 50 schools, 3 phases at the time, primary, middle, and secondary, and we went to visit every school and took the kids in that age out of every class, did a skin prick test, took a history, did the food challenge, the whole shebang. This is why actually people couldn't believe we could pull this off on the scale, but I was blessed with a fantastic team. The bottom row, middle picture, is my daughter, who was in the 6-year-old cohort. Of course, I had to make sure that my own child participated because at the time I was living on the Isle of Wight. So overall, 3,000 kids, over 3,000 kids in the study, and you can see the scale of the operation. I'm not doing this study any justice. I'm summarizing it in 1 slide, or possibly 2. So what we did find out was actually many people report they have food allergy. Much fewer are sensitized to food allergen, and fewer still who have really proven food allergy. And this naturally attracted a lot of interest in the media, and the data you will see, and when I did my British Science Festival talk, I had a BBC news clip in there. The data around 2 million allergic is based on the FAIR studies. So lots of different publications came out from this one study, and it's still going on because I'm dearly love to follow these children into adulthood. But remember, the challenge the Department of Health said, we don't have evidence. We much rather be cautious and say don't eat peanuts. But here I was, had the exact evidence, because I had cohorts of kids in different ages, born in the same geography, and I could actually demonstrate to them that rate of allergy hasn't gone up because mothers are eating peanuts. And in 2009, the government decided to revise its advice. And I was delighted that they did that. It took almost a decade to go back and prove the point that the initial advice was wrong. You won't be surprised, that was just in time, one of my ref impact case studies. So I was delighted to quote the CMO as the evidence and the Department of Health guidelines. So, management of food allergy. Well, there's no cure. So the only way is to avoid and meticulous attention to labeling. Sometimes labeling is silly. A tin of tuna saying it contains tuna, or egg saying it contains egg, that's silly. And many food industry had this defensive labeling. Do you remember it? May contain. You had rows and rows of it in supermarket. Of course, food does appear in places you don't expect it to. Wheat in soy, soy in peanut butter, wheat in camembert cheese. But the only solution was to really pay attention to the labeling, which wasn't helpful at the time. So EU directive came in 2007 and said, well, actually, all the businesses, you have just about a year to prove to us whether your product has or does not have the following ingredients. Okay? And if you can demonstrate it doesn't have it and is robust scientific evidence, then you don't have to label your product contains this. But if the scientific evidence is not good enough, I'm afraid you have to label it. And they approached me to be the expert assessor for them for all their peanut, milk, wheat, and soy dossiers. This was quite a mammoth job because you can imagine from the wine manufacturers to the beer to the cheese, all of them. But I actually quite enjoyed my Monday trips to Brussels. We met on a Monday and I had a very supportive team who allowed me to do this. And I thoroughly enjoyed the work with EFSA, the European Food Safety Authority. I did this over 1 year, very intensively. And what did we learn? Well, I learned that actually there's lots of fish in wine, particularly red wine, because isinglass, which is extracted from grand gallbladder of fish, is a very commonly used clarifying agent in red wine. I learned that there is milk and egg in beer and wine, nuts in whiskey and gin. I think I knew about the gin and nuts, but, it was quite surprising. Most of the dossiers they supplied were poor and they had to do further tests. I left EFSA really quite with fond memories. And then about in 2015, EFSA had grown. They had become a really big organization. They had their own research funding, giving fellowship, giving research grants, and they approached me to come in and work with them and be part of the panel on dietetic products, nutrition, and allergies. And they moved offices from Brussels to Parma in northern Italy. So many of you who work with me know every now and then I go to EFSA headquarters and I chair the allergy working group. And it's really quite thrilling to be at the heart of knowing what is the best food allergy research going on, what are the safety and the label issues. When it comes to the labeling, let me tell you, since 2014, things have moved on so far that it's not only packaged food, all the food, the 14 that I shared with you, they have to be declared on unpackaged food. So in delis, in cafes, in restaurants, you can now ask, does this contain peanuts? And they have to say yes or no, okay? That has made a significant difference to the allergic consumer and eating out. So food allergy research in the past 50 years, because it is a new area, really has focused on epidemiology, on risk factors. I think the way to go in future is around the safety issue. We are having a lot of novel food introduced into our diet. The notion of kiwi allergy was unheard of. It is now a fairly common type of allergy in the allergy clinics. And kiwi came to the British diet in 1985. So novel foods, different type of analysis of allergens in food, and the new therapeutic options are the futures. I'm going to round up by just talking very briefly about eczema, because that's the other area, and I'm going to kind of try to share some couple of interesting trials that I think you may be interested to know about. Eczema is another of those allergic diseases. It's a terrible condition. The trigger factor, as I already told you, if you are food allergic, could be the food allergens, but there are other trigger factors. So whether it is humidity, temperature, irritant, various other conditions. The way to treat it is to, literally, I always say this, to chuck things at it. Usually topically, so it is emollient, it is creams, it's steroids, it's the new new topical immunomodulators, and sometimes systemic treatments. But I've always been interested, and this is talking as a mother of a son with, well, he's here, with eczema, is actually, are there other interventions? Are there other things apart from the drugs that can help the symptoms? So in NHS and in Department of Health, there is this wonderful body that I was part of it setting up called the James Lind Alliance. Some of you may have heard of James Lind. He's a Scottish physician responsible for demonstrating that oranges and lemons or vitamin C can cure scurvy. So this particular alliance was named after him, and it brings together researchers, clinicians, patients to do priority setting. What are the uncertainties? What are the areas? What are the questions that need answering? And this was one of the top questions for them, non-pharmacological intervention in eczema. When I discovered this, I then took this question to what I regard as the center of excellence in this country for anything to do with dermatology, and that is the Center for Evidence-Based Dermatology at University of Nottingham, headed by Howell Williams, who I met first when we were both doing that MSc in epidemiology in the London School of Hygiene. He's a dermatologist by background. And I kept going at him, this is the sort of study we need to do. We really need to do this. We really need to think of applying for a grant to do this. And I was very interested in two particular interventions. One was soft water. In fact, it was the Nottingham team who had shown there might be some linkage between water hardness and eczema prevalence and eczema exacerbation. You hear from patients when they move from hard water area and go and have a weekend in Yorkshire, their eczema disappears overnight. So there is something in that, and we thought, okay, let's do a study. And I eventually, going on and on, I persuaded Howell to work with me on a grant application that we submitted to Health Technology Assessment, NIHR, just multi-center study looking at whether you soften water in hard water area helps eczema. Lovely study, very clear objectives. All we wanted to know is, does this thing work? Parallel clinical trials, so we had two arms, a group of children who had the water softeners right at the beginning and a group who just had the standard eczema care, and then we switched them across. It was quite a complex trial because we had to work with, in effect, a group plumbing companies, because we had to make sure they get these water softeners into their homes in a timely fashion. The study was done on a number of sites. Isle of Wight, Portsmouth, I led on those areas, London, Cambridge, Leicester, Nottingham, Boston, and Lincoln. So this is, for those of you who know about consort statement, this is the flow. We ended up with very few dropout rate at the end, but actually only half of the patients who we initially assessed ended up in the trial because their homes were not suitable for installing these water softeners. The results, nothing, okay? Absolutely no effect on management of eczema. And we all, because it was done as an assessor blind, at the meeting that we unveiled the results, we all had to write whether we thought it worked or not. And we were actually quite surprised because quite a few of us thought we would have the evidence that this worked. It didn't work. We got into a bit of a bash with the water softener industry, but hey ho. The project was published in PLOS Medicine, and that was my second impact case study for Ref 2014. So Howell looked like this, really serene. I think Stephen in the audience knows him very well. But I think by the end of this trial, he had enough of me. And when I suggested to him, let's do another trial, he said, absolutely not. I will work with you, but I would not lead on a trial. But I was interested on one other area, and that was silk clothing. I knew NHS was spending around £2 million a year on these silk garments. Cleverly, the industry disguises it as a device. If you are disguised as a medical device, the actual evidence base you need is much weaker than if it is a drug. So the industry itself had done 3 small clinical trials with 79 kids, and hey-ho, before we knew it, GPs across the country were prescribing these as a sweetie. So this is where the clothes trial were born. Howell didn't come on board, but I managed to persuade his co-director, Professor Kim Thomas, and this time round, quite a few sites said, no more, these are too complex. So the study sites were just Portsmouth, Isle of Wight, Cambridge, Nottingham, and London. It was quite a large study, 300 children again, and we had a number of outcomes this time, not only the primary outcomes, but a range of secondary outcomes, because we learned from the water softener study that we should have probably looked at a broader range of outcomes. This is the meeting where we unveiled the results on primary outcomes. Again, no evidence of effectiveness that these garments that NHS is spending over 2 million on is working. Not only the primary outcome, nothing on the secondary outcome. So this was published earlier on, and it was one of my earlier publications with University of Brighton in the address, which I was particularly proud of. So I've taken you through a whirlwind of some of the work I have done. It's a young field. So I talked a bit about the epidemiology of it, about diagnosis, management. There is a lot more questions which need to be answered. When I got my PhD, my supervisor gave me a lovely card, a blank card, which I think he must have had in his desk. But he took time to write this message in it for me. And this message has stayed with me. And I want to finish with the last point. The one most important word is we. And what I shared with you, I could have not shared with you if it wasn't for the people who I have worked with over the many years to come. They have been absolutely vital to any success that I have had, and I hope I have contributed to theirs. There is one group that I want to single out, and it's my PhD students. I'm probably not the easiest supervisors, certainly probably not there for them 24/7 as Bob was for me, but I do my best. I want to and all of them have gone on to have wonderful career, not only in academia, but wonderful career. Those who have stayed in academia, they have changed areas. They are not in the allergy area. Some are still in the allergy area. I want to highlight 2 of them with you, Jonathan Houlihan and Karina Venter. Jonathan is that young pediatrician who came in to do his PhD. Sadly, none of these 2 examples I'm sharing with you are in UK because Jonathan went to Ireland He's now head of pediatrics and childhood at University College Cork. And he took allergy to Ireland. He established the first association of allergy and immunology. And he became chair of the first patient network. He is doing great things, big grants. I'm very proud of what Jonathan is doing. And it's lovely to be invited. Well, twice I have been invited to examine his PhD students. That's quite a thing. The second person is Corina Venter, who was that pediatric dietitian whose career has taken off. She is in Denver at the moment. Corina has written a book which was published 2 years ago, Food Hypersensitivity, Diagnosis and Managing Food Allergy and Intolerance. It is really all anybody needs to know about food allergy. I am very proud that she's taken that mammoth task of bringing it all under one publication. She's also the only person who's helped to be on the expert panel for guidelines for allergy prevention in US, in EU, and in UK. That is quite a task. So when I look back at my research to date, I don't think really my greatest achievement have been the grants or indeed the papers, but it has been the ability to develop ability in others. And Corina and Jonathan are two that I'm particularly proud of. Thank you. Thank you.